I've been asked to talk about ACL and meniscus injuries. So we're going to kind of go through mainly ACLs and maybe a little bit at the end kind of about isolated meniscus injuries and a little bit of what we do with them from an orthopedic standpoint. Just briefly, I got no financial disclosures to give you guys. A quick biography of myself. I kind of lived a handful of places throughout the west, middle of the country, and then out in the East Coast for fellowship, and then I was in the Navy for about 14 years, been up here for about 2.5 years or so now. So looking at the knee, just kind of a basic anatomy stuff here. The ACL is an intra-articular ligament here. You can see it kind of right in the center of the knee and the intercondylar notch attaching over in the tibial spine. It overall has a fairly poor blood supply. Now it has enough of a blood supply when you tear your ACL, you get a large hemarthrosis and effusion afterwards, but overall the blood supply is not great, and that's why things like partial injuries of the ACL tend to not do really well in terms of having a healing response or regaining stability. And there's two bundles of the ACL. There's some literature out there about trying to reconstruct both. Most of the time when we're talking about ACL reconstructions and injuries, both bundles, which are really confluent with each other, are torn, and generally we kind of reconstruct with a single bundle ACL. Function of the ACL, it's really kind of a primary stabilizer to anterior translation. If you think of the anterior drawer test or Lockman test that you do, that's exactly what it's kind of designed to do, is to give you basically anterior translation stability and also some degree of rotational stability. Very important for any kind of cutting or twisting activities or sports that are associated with that. I think it's a picture of Marcus Lattimore, who had a multi-ligamentous knee over there. When we talk about ACLs, we kind of have this rule of thirds that we used to talk about, and it may be a little bit antiquated at this point, but really kind of a third of patients with an ACL tear will have stability or instability with activities of daily living and sports activities. A third of patients would do well with just regular activities of daily living, but if they tried to return to cutting sports, they'd have problems. And then a third of patients really don't have a lot of issues with an ACL tear, but that's really kind of more for your older athlete and maybe someone outside of the collegiate ranks or competitive athletic ranks. But overall, if I were to tear my ACL, I don't know if I'd need it for ADLs. I probably just wouldn't go back to play men's league basketball or anything. Prevention, this is kind of a big topic these days with ACLs. There's a lot out there about ACL prevention with our young athletes, and especially a lot focused on our young female athletes. I'm sure that you guys probably all have heard of this or do some of this with your local schools and with your athletes. But there's kind of a lot to this in terms of what we do with them, with proprioception training specifically, a lot of cross training, and then conditioning as well, because a lot of these ACL and knee injuries occur as we kind of get later into events when you have some degree of fatigue, and it puts you at higher risk for injury. Overall, the mechanism of injury, there's a lot of these real gruesome ones that are a high impact contact type of injuries, but really most of the ACLs that are torn out there are going to be a non-contact injury. Here's the kind of the famous one from this year with Jimmy Garoppolo just trying to cut or staying in bounds with an ACL tear. Most of your athletes will hear a pop in the knee or describe feeling that sort of pop. You'll get a rapid hemarthrosis. Within about an hour to 2 hours, the knee will be, pretty swollen and painful. And generally, these athletes are not able to continue with sporting activities. A minor MCL strain, sometimes a minor meniscus injury, they'll be able to continue playing. It'll kind of hurt a little, and they'll be able to get through. And when they cool down is when they really notice it. ACL injuries, these are generally kind of, they're being helped off the field and they're not returning to play. It really kind of is self-diagnosed from that standpoint. This is the quick test that we're usually doing on the sidelines when you initially evaluate these athletes. A lot of times if you can kind of catch it right after the injury, before some of the swelling and real pain is set in, you can get an idea. So this is why we're out there kind of checking right away to see if we can really feel there's increased translation. You always have the contralateral side to kind of get a normal for that patient to kind of feel real quick. But here you're just stabilizing the femur with one hand, pulling anteriorly, and you're feeling for that end point. We kind of grade these on a 1 to 3 and whether or not they have a firm endpoint. But really in the end, you're just looking to feel, does this thing translate anteriorly, especially anything more than about 5 to 8 millimeters, and is there a good endpoint at the end? It should kind of snap and feel nice and taut when you do that anterior translation. Looking at other ways for the diagnosis, again, the Lachman, which I showed, they're kind of the most sensitive here. The pivot shift, that's generally something we're doing in the office setting, and usually your knee has to be a little more quiescent, calm down. You're not going to be able to do this in an acute injury, but basically you're kind of putting an axial load on it, you're internally rotating, and then you're flexing, you're kind of feeling that knee. It'll either pop or glide, and we can kind of demonstrate this when we do some of the physical exam stuff later on today, because it's much easier to show than to describe here. We do see a lot of concomitant meniscus tears, and bucket handle tears are the ones that we're most concerned about recognizing early on. And again, that anterior drawer where you have the patient kind of in the supine position, kind of giving them both a posterior translation and then anterior as well, is also helpful. But we find that the Lachman's better where you're actually stabilizing the femur. Most of your young athletes, or really athletes of any age who have an ACL injury, we recommend getting an x-ray fairly soon on these. You know, they're usually patients that should be seen in the ED or maybe at least urgent care within about 24 hours. We want to make sure that we don't see a fracture there. This is what we call a Sagan fracture here. We just see this minor little chip. Doesn't look like much, but that's very pathognomonic for a ACL tear, and is basically the anterior lateral capsule kind of pulling a little fleck of bone off of it. But when we have younger athletes, especially who are not fully skeletally mature, we want to get an x-ray, because at times, instead of actually tearing their ACL, they will pull off one of the tibial spines at the attachment there, and that's something that we want to get to surgically fairly quickly, usually within a week or so, and we can actually fix that as opposed to reconstructing the ACL. MRI, most all of your patients with ACL injuries, we're going to be getting an MRI. But really the kind of key here is we should be able to diagnose the ACL injury with examination and history alone. Usually this is A, confirmatory of your diagnosis, and B, we're doing it more to look for other injuries. And those other injuries would be to see if it's a multiligamentous injury like the MCL, PCL, any of the other structures. And you're also looking for bone bruise, any osteochondral lesions, because generally when you have this pretty traumatic subluxation episode, you'll get bone bruise in that lateral compartment. Occasionally, you'll also knock off pieces of cartilage or cartilage with underlying bone. We want to recognize that very early, because that will change when we look at treating these patients. And you're also looking for meniscus tears, specifically if you have something like a bucket handle tear, and I'll show you a picture of that in a minute, because if you get a meniscus tear that can be repaired, if we kind of let that wait 6-8 weeks, that may be non-repairable in a young patient, which may affect their outcome, as opposed to if we see that, we're probably going to push to trying to fix their ACL and their meniscus earlier. Just a brief picture here of what a normal ACL looks like on the left. You see that nice structure running from the posterior femur to kind of the anterior tibia there, right over here. And then you can see the other picture. This is what you'll see almost every time. It's pretty, pretty dramatic like that when you see it, that the ACL is kind of ruptured mid-substance. And the other thing about this is obviously not a real acute one, because you don't have a huge effusion associated with it. Our goal when we look at reconstructing ACLs, number one is restoring knee stability, both kind of that translation and rotary stability, we'll say. We want to kind of keep the normal motion. One of the big things here is protecting meniscal and chondral surfaces. So, if your athlete goes back, their mid-season tears their ACL and it kind of calms down on them and goes back and has recurrent subluxation episodes or kind of re-injuries, you worry about at that point. If your meniscus and chondral surfaces look fine before, you can definitely kind of re-injure with every single instability episode you have moving forward. A lot of the rehab we do focuses on the quads and hamstrings. You'll see that these patients almost right away will have a bad atrophy within almost a week or so afterwards. Again, surgical results of these things, there is a lot of kind of factors go into it, whether it's patient selection, how you do it, their rehab afterwards, or compliance. So there's a lot that goes into kind of how these patients do in the end. And there's also lots of controversies from a surgical standpoint in terms of what we do with them. Graft selection, whether we're taking a portion of their patella tendon or the hamstrings, and occasionally if we're using things like the allograft or cadaver tissue. Those are all some of the controversies, and there's strong opinions for and against each one of those. How we fix them, this one up here in the top left is what we call like a suspensory fixation, and we'd actually kind of loop a piece of graft over that, and then that little button on the top would be on the outside of the bone, and basically kind of it It slides through and then it kind of locks outside the bone and allows that ACL to kind of be suspended, we say, and then the bone will grow into it. Where the bottom picture, I think a little more commonly used for like tibial fixation, is these interference screws where you have this screw that basically goes in and just gives this kind of massive compression around your graft to hold it in place until you get bony ingrowth. In terms of your rehabilitation protocol, I think a lot of our physical therapists work with the sports doctors to really kind of isolate specific protocols for their patients. But you generally will say return to play is around 6 months, and is a lot of times based on their motion and strength and stability in the knee. So it's somewhat individualized. Kind of a common thing that we discuss with a lot of our patients, especially some of our older athletes, really this kind of no need that's too bad that you can't make it worse with surgery, meaning that sometimes we get these multi-ligamentous knees in patients who are really kind of non-athletes at this point. And some of these major reconstructive episodes we have kind of at our disposal, in the end, may not make them a whole lot better. Our young athletes are a little bit different story, though. In terms of overall ACL management, there's kind of just some things or principles out there. Not all ACL deficient knees need surgery. Again, there's some protective effect of having the ACL in terms of decreasing recurrent instability episodes. This is really more for the middle to older age athlete. I would say your younger athletes are almost always going to have an ACL reconstruction. They don't need emergent surgery. You hear about guys in the NFL or other sports tear their ACL and 5 days later they're flown off and they're getting their ACL reconstructed. That isn't really the standard of care for most of our athletes. Our general gestalt is that you want to kind of get the knee to calm down, get some of the swelling down a little bit, get their motion back, and then look at, you will say, a subacute reconstruction. A lot of times the pros are doing this so they can really kind of look at, next season getting the rehab going as soon as possible. And they also have a lot more therapy and time and modalities at their disposal than our average athlete would. Even if you have a multi-ligamentous knee, the most common would be having your anterior cruciate ligament and the medial collateral ligament injured. They don't need to do emergent surgery either. Sometimes we kind of brace them for a period of time, get the MCL to heal completely, and then move forward with reconstruction of the ACL at a later date, 6 to 8 weeks later. There's some thought too that our older athletes, we just put them in a brace and they'd be fine. We find that, conversely, they don't all do well either. That, sometimes our, 40, 50-year-old people, the one that can remain active, they don't always do well with just kind of rehabbing them and getting them back. Sometimes they have a lot of instability that does well with ACL reconstruction. And there is some disability associated with it. Not everybody gets back to their prior level of play. Even with optimal surgical outcomes and a rehabilitation protocol, some patients just never quite get back to where they were. They still have some, some micro instability and some pain that they just don't quite trust the knee. One of the, we'll say, somewhat hot topics here is kind of the skeletally immature athlete. And a lot of these are going to be your patients who are their, 7th, 8th, 9th grade. They're not quite there for skeletal maturity. They're kind of right at their, peak growth velocity. And so our concern with them, with their ACL tears, is that most of the mechanisms we have for fixing the ACL are going to cross the physis or the growth plate. There's kind of conflicting data out there. There's some data that says you can drill a 8 to 10 millimeter hole through that right in the middle and it doesn't affect their growth. But there's also concern and then some other data that just says, well, if you're off a little bit or you're kind of oblique when you go through it, you make a bigger path through that physis, that you can arrest the growth at an area, and then you kind of either have some sort of angular deformity of the knee, or the other worry would be that you actually kind of just cause the growth plate to prematurely close and you end up with a leg length discrepancy. Fairly uncommon, but in the case if they're fairly young and they have a lot of growth left, we also look at doing what's called a physeal sparing ACL reconstruction. And that picture on the side there shows you that basically the blue is the physis, and instead of trying to make in our standard tunnels, which I'll show you in a second, we use tunnels that are that kind of get away from that physis. A little bit harder to reconstruct them using this method, a little maybe higher rate of complication. Sometimes if they're fairly stable and they're young, we may just wait a little bit of time, especially if they're not a high level athlete that's in real competitive or something, wait a little bit of time, let them get towards skeletal maturity, then reconstruct at that time. There's some sport-specific considerations. I'm not going to go through each one of these here, but If you have athletes that are doing a lot of, wrestlers who are going to be on the knee a lot, going to have a lot of direct contact over there, you may consider reconstructing with the hamstring as opposed to a patella tendon, because there's going to be a lot of direct pressure, soreness over that area. Skiing maybe similar thing. A lot of football players, however, because we like a real stiff graft there, and especially a lot of the pro players, they do a bone tendon bone graft, so they use the one in the front because there's a little bit higher initial rigid fixation. You can kind of get back to be a little bit more aggressive with physical therapy early on. The one thing I was going to point out here when you get these, bad knee injuries, the one that we'd never want to miss would be something like a knee dislocation, right? This is, very rare, but I think there's one this year in the college ranks for Central Florida where, a kid probably almost lost his leg, and I think he was emergently had to undergo revascularization. So the reason we worry about these knee dislocations is because the popliteal vessels in the back of the knee they have some fairly rigid kind of envelopment with fascia, and so if you really kind of translate that knee significantly, you can tear the artery back there, and then you disrupt blood supply to the basically lower extremity, and sometimes unfortunately can result in things like amputation. So knee dislocation, even if it kind of you're able to pop it back into the sidelines, check vascular status. These are some things that need to go right to the emergency room. We do some advanced studies there in terms of sometimes even arteriograms to ensure that there's no even intimal tears in the artery. Again, these are going to be the one in a career sort of things that you see, but these are the ones too that you never want to miss, and you get them shipped along as quick as you can. In terms of meniscus tears, this is a picture here of what a bucket handle tear looks like. You go in with the scope, and instead of seeing a nice notch there where you can see the ACL or what was left of the ACL, you get this big folded piece of tissue. And that's what a bucket handle meniscus tear looks like when you see it. And you basically have to determine, hey, is this from the medial or lateral side? And then you take something blunt and try to push it in there and reduce it. And I'll show you a picture of what it looks like when it's reduced and then fixed in place. Acutely, a little higher rate of lateral meniscus tears, but chronically, because the medial meniscus is more rigidly fixed there, chronically it's a secondary stabilizer, and therefore if the ACL is out, it takes more stress and the higher rate of tears of the medial meniscus. We do some other radiographic considerations. So if I get a patient who looks like this on your left, has a good-looking knee, they're probably going to be a good candidate for ACL reconstruction. I guess someone who comes in with kind of a loose, sloppy knee, but also has a lot of pain, and they come in with the x-ray there with a lot of arthritis. And this, sometimes we see guys in their, mid-40s at the earliest. We see this sort of thing. They're more a candidate for, sometimes an arthroplasty as opposed to an ACL reconstruction because they have a lot of arthritis. You tighten that knee up, and they're probably not going to be all that happy. And I've actually done a number of cases where we do a combined anterior cruciate ligament and a partial knee replacement in these to get, patients who still want to be reasonably active back to like things like tennis or racquetball, not high-level cutting sports. In terms of bracing, they're pretty expensive. There's a huge market out there for them, but there's really not a lot of hard science in terms of bracing for prevention. Patient compliance is an issue with these. You get your interior linemen, they don't seem to mind wearing these, but your cutting athletes who are kind of your skill position players, soccer players, most of them will find these somewhat kind of cumbersome to wear. Our goal generally these days is to reconstruct the ACL and rehab it at the point where bracing is non-mandatory, and I think a lot of us now don't even prescribe braces for our ACL post-recovery. In terms of how we do the ACL reconstructions, this picture on the left shows you this is what was called a transtibial technique, where we drill a hole through the tibia, and then we use that same hole to, on that right side, we have this little guide, drill a hole through the femur, and we try to reconstruct this as anatomically correct as possible. There's a couple ways to do it. The one on the left here shows you this is kind of drilling a hole again up into the femur through there. That we also sometimes use what's called an anterior medial portal to try to get that ACL footprint down a little bit farther on the notch. There's some thought that maybe that gives you a little bit more rotational stability. Both of them will give you good translation instability or stability with this, but sometimes a little bit of rotational stability is improved by changing your femoral footprint over there. Again, these are all debatable. There's a lot of people who do them, have great results doing one way or the other for multiple years, so there's not a right or wrong answer in terms of how do you reconstruct them. Again, this is kind of a picture showing, how we kind of fix these. This is with a bone patella bone, where you have a bone block that you're fixing with an interference screw to hold them in place, and that's a very rigid fixation. Usually, that bone block we'll say is about 10 millimeters. We drill a hole that's maybe 11 millimeters, and then we take another screw that's maybe 10 millimeters, so it just compresses the heck out of everything in there, and you're probably more likely to fail at the graft than you are at the fixation early on. So here's just a picture of what these grafts look like. And this right here, there's bone on either end of that graft with patella tendon in the middle. So when you do this, you take about a 10 millimeter width of your patella right in the middle. You kind of slice down on either side, take the middle third of the patella tendon, and then we cut out a portion of the tibial tubercle. So that's what the bone patella tendon bone graft will actually look like. One of the advantages there is that you have bone that can then ingrow into the femur and tibia when you place it. We also use hamstring, which is taking the medial hamstrings over here, and then also allograft tissue. I kind of just talked about each one of them very briefly. The hamstrings, this is just a picture of how we harvest them. We have these things called a tendon stripper or tendon harvester, and we take the gracilis and the semitendinosus over here, and we just kind of strip the tendon. You will get some reconstitution of kind of some scar-like tendon, and you feel someone that's got a hamstring graft. You'll kind of feel over the medial hamstring a year later. You'll feel some reconstitution, but it's not quite the same. They sometimes will have some pain over in that area that persists and a little bit of hamstring weakness afterwards. So there is a downside to it, but the thought is maybe there's a little bit less morbidity than taking the patella tendon. It's overall, the tendons themselves are very strong, but the construct's not quite as stiff because it's hard to really fix them in the tibia and the femur quite as rigidly as you can two blocks of bone on either side. And because a lot of times we use that what we call suspensory graft, sometimes the tunnels where we drill, and we may drill like a 1 centimeter diameter tunnel in there, over time there could be some motion that ends up kind of dilating that tunnel with the kind of activity. This again is a picture of how we take out that bone tendon bone. Again, it has great kind of ingrowth, early rigid fixation with this. It's a little bit stiffer construct, which may allow you to kind of start rehabbing a little bit early. But again, when you think of anybody taking a chunk of bone out of your kneecap, you have patellar pain afterwards. And there is always that risk of things like patellar fracture, especially kind of early on, because you have compromised the integrity of the patella by taking out a chunk of bone. Allograft or cadaver tissues. This is generally kind of in your 40 and over crowd. It's going to be rare that we use these in young, active patients. A couple of exceptions would be really kind of petite, small patients where we harvest a graft and we get in there and it just is too small. We can't really utilize it for reconstruction, so we can augment with allograft tissue. Also multiligamentous knee reconstruction. So if you're having to reconstruct the ACL, PCL, medial meniscus, medial collateral ligament. When you get that sort of situation, there's only so many places you can kind of steal tendons and tissue from the person's own body, and so utilizing allograft is a good option then. But in your high school kid with a torn ACL, this is probably not a great option for him. The reason being that there's a little slower incorporation, meaning that you're taking basically cadaver tissue trying to get your bone to grow into it. So it just takes a while for that graft to, we could say, fully mature and ingrow. There's a higher re-rupture rate. You can read all kinds of literature about this, that these are the patients that re-rupture their ACL, a year or two out. And then, of course, there's things like potential for disease transmission. I think that's really low because they do a really good job of testing these now. But it has a benefit. If I had an ACL at this point in my life, I would probably look at doing an allograft because there's no donor site morbidity, be back quicker. And outside of goofing off with my kids, I don't play a lot of high-level sports anymore or anything. But again, most studies in your active patient, athlete, allograft is an inferior construct. So you want to use kind of your own tissue. Surgery timing, again, we said, hey, you don't have to do these acutely. You got a little bit of time. You want to kind of get the motion back, delay your reconstruction and to ensure that your knee isn't stiff, because that can lead to more problems. You operate on a stiff knee, it's probably going to be stiff when you're done. So 3 weeks or so is a good time frame. Sometimes we look at kind of the seasonal sports in terms of trying to get them maybe a little bit earlier, or again, if you have something like a displaced meniscus you have to take care of, that's probably an option that you want to get at as quick as possible. The results, overall, 95% plus are very happy though, but 70% of patients really get back to their prior level. And you see this all the time. There's a lot of success stories here out there about patients who return, but for every one of those, there's a few that you don't really hear too much about that never quite got back to where they wanted to be. Kind of the keys here with rehabilitation: early motion, you're early working on your quadricep mechanism, and we usually let these patients weight bear as tolerated, and again, most of us are not bracing them. 6 months or so is kind of an average return to play. I think we kind of covered all of this. I'm trying to keep us going here. Moving on to meniscus injuries. Again, multiple meniscus surgeries of all kind of ages in life. The function of the meniscus, this is a famous, not famous, but a kind of a widely used picture from Arnosky looking at the vascularization of the meniscus. The meniscus over here is kind of that little crescent-shaped structure. And what this is showing here, that's the blood supply. And you can see overall on the kind of to your far left, there seems to be a lot of blood supply. And you look in the meniscus itself, limited to no blood supply, and that's why we have a hard time getting meniscus to heal. It functions as a kind of a load-bearing structure in the knee, a kind of a little bit of a shock absorber, and it also, especially on the medial side, enhances joint stability. So if you cut out someone's medial meniscus, they're going to have more translation there and more kind of a feeling of instability. Isolated meniscus injuries, again, non-contact. This shows kind of the different types of tears looking at the meniscus. Again, the one we worry about, things like the bucket handle tears, that's going to be kind of your young kids. And sometimes these other ones here we see as well concomitant with ACL. The only time this is an urgent issue is if they get a locked meniscus. They're kind of stuck at 15 degrees, it can't extend, or they're stuck in a flex position. These are ones that usually you're going to send on to the emergency department. The way we kind of deal with these a lot of times is we either kind of sedate them or we inject the knee with a bunch of local anesthetic until we kind of calm it down and get them to kind of relax enough that you can kind of at least try to manipulate the knee to get that meniscus to unlock. Very rare that needs to go to surgery right away, but you can't leave them obviously with the knee stuck in 90 degrees of flexion. Our treatment for meniscus tear is really kind of based on a handful of things. Chronic meniscus tears really aren't amenable to fixation. The types of tears too, if you have just like a little flap tear, just kind of a little radial tear, you can't really fix that when it's in that non-vascularized area. The ones that are amenable to fixation are like these tears here where you have them right here because the blood supply is all on the outside of the meniscus. Anything over in here, you try to fix it, you're going to be back 2 months later taking that out. And here's kind of a picture of what it looks like when they're fixed. You can kind of see those little blue things. That's just the suture that we use to fix these. If you're doing just an isolated meniscectomy, you really have no restrictions. You can get back kind of whenever you're feeling comfortable. For sporting activities, sometimes it may be 2 to 4 weeks before you're really kind of feeling good, but it doesn't take that long. You repair a meniscus, different story. Then we kind of lock them in a brace. They can weight bearing extension only. We don't let them do any flexion weight bearing for like 4 to 6 weeks to allow for healing of that meniscus. And it takes quite a while, man, about 4 months or so before you really let them get back. So the difference between doing a meniscectomy and a meniscus repair, not that much harder for the surgeon, a big deal for the rehab and recovery and where they're going to be. That's all I got. Thank you.